very relevant and interesting and actually a controversial topic. So we have a lot of questions already in our chat box. So allow me to go ahead and ask the first question. So for the first question, is there any way for the healthcare system to predict the emergence of new variants of concern, especially that of COVID-19? And are there any risk factors or factors considered which would help increase the probability of predicting the surge of cases?
Right. So, thanks for the question, Gabsy. Thank you for whoever posted that question. In the lecture, we talked about why variants of concern are called as such, no? Decrease yung effectiveness ng either vaccines or my testing issue or increased transmissibility, etc. So there's a set definition that the WHO uses to classify these vaccines as variants of concern. And before it becomes a variant of concern, there's actually like two other steps. No? Below that is a variant of interest. No? So the WHO has this very extensive surveillance looking at variants, no? And then as there's more evidence showing that the variant is problematic, then that's when variants of concern become elevated. So yes, there's a way to track, and the WHO is tracking it already.
Okay, thank you, sir, for it. We have another question. Actually, this is more of a general question for vaccination. So, for adolescent females with ongoing HPV vaccination due for the third dose, but also scheduled for COVID vaccination, what must be the interval time between each vaccine administration?
So, the HPV vaccine, we need to know about the nature of what we're giving. And in terms of basic vaccinology principles, the only vaccines that really need special scheduling are live vaccines. HPV is not one of them. No? So, in terms of giving HPV in addition or with COVID vaccines, I don't think that there's a time frame that we need to observe. It used to be that we recommended a spacing, no, because we wanted to see side effects, adverse event monitoring, etc. But the CDC has actually revised those guidelines and now says there's no need to space it out. It might be a good idea to keep maybe 1 or 2 weeks between, just so you can observe for adverse events. But theoretically speaking, there's no need to do that.
Yes, sir, I will totally agree with you, especially for COVID vaccines, wherein some may actually experience adverse events, even if minor or mild adverse events. And then the third question we have here, is there really a need for a booster dose? And probably a follow-up question on that is, do we have information with regards to the implementation of booster doses in the Philippines?
We probably have seen the HTAC recommendations. The HTAC has actually said if there's enough vaccines, then we need to consider giving a booster dose to high-risk groups, immunocompromised healthcare workers, etc. But again, the statement was premised on having enough booster doses or enough vaccine doses. Like I said in my lecture, this really is a question of equity. In fact, the WHO has recommended a moratorium on booster doses sana until the end of the year. They have goals kasi to hit, no? They want to hit this much percent of the population, I think 20% by the end of the year, and they want to hit 70% sana of the global population by June of 2022. But they cannot do that if there are areas in the globe that are lacking, no? So, syempre, WHO, they're looking at it from a public health perspective. And really, I really believe in what they say, that there's, no one is safe until everyone is safe. So we want to give the vaccines with the greatest impact. And getting the first dose in every arm will have a better impact than giving booster doses in a select few people. However, I also said in my lecture, in immunocompromised patients or say healthcare workers who are at very high risk for getting COVID, then we might need to reconsider our decision on boosters. No? Baka kailangan, given the evidence, especially now there's real world evidence of the waning immunity. No? So maybe we really need to do the boosters.
And in case, again, boosters will be implemented in the future. And given the decline in the vaccine effectiveness of the COVID vaccines, available COVID vaccines, so you think booster doses will be given at an annual basis, similar to flu vaccines?
Well, we go by what the data shows, no? And as right now, the data only shows that there's waning immunity and we need to boost. We're not there yet doon sa part where we need to give it annually or not, no? We need more data. So we don't know the answer to that. It's possible, especially if COVID-19 becomes endemic. I don't know that we can classify COVID as endemic just yet. But we await more data to say, to make a decision on whether we really need annual vaccinations. It depends on many things, including the occurrence of variants.
So you mentioned, sir, that we have limited information as of this time regarding boosters. And actually, based on your talk, you have explained about efficacy and effectiveness. And most of our data now on boosters are actually on immunogenicity. So, with this, can you enlighten us what's the difference of
15 minutes yung open
immunogenicity
forum nila.
studies versus that of
Kasi talagang
efficacy
iniklian ni
studies?
Karl yung
And do we have any efficacy or
Mm-mm.
effectiveness studies on
6:30.
these boosters?
Alright, I actually planted this question with Gabsy because when I recorded my lecture, there was one important study that I wasn't able to cover. This was recently published, I think in October. I presented to you the immunogenicity studies from the US, yung mix and match. But when in October, nag-publish ang NEJM, real-world experience from Israel. No? And in that study, so just a background, in Israel, they were able to vaccinate more than 50% of their population by March of 2021. And then they looked at giving boosters sometime middle of 2021 as well. And that data shows na giving a booster actually decreases your risk for a breakthrough infection by 11-fold, no? And it decreases your risk for a severe infection by almost 20-fold. So this is real-world evidence, no? Kasi yung pag-immunogenicity, you're only really looking at one component of the immune system. Whereas when you're looking at vaccine effectiveness studies or real-world effectiveness studies, you're looking at overall the totality. So this is very compelling evidence that I think we really need to give boosters to high-risk groups. So we await the decision of the DOH. Wala pa silang sinasabi about the details of the rollout. Pero from what I hear, it might be out soon.
So mukha talagang doon talagang to go natin to boosters. Eventually, maybe not now, but eventually.
And to clarify, this is for high-risk groups.
Yes.
I still stand by what I said in the lecture that I think for the general population, the primary series will still stand and will be very effective.
So in relation to that, sir, so we all know that the most common vaccine that Filipinos have received is the inactivated vaccine. And the studies that you mentioned actually are, most of them, the primary series were given with mRNA vaccines. So do we have information regarding giving booster doses to those who were previously given inactivated vaccines initially?
The one study that I found was just an immunogenicity study. I presented the Sinovac paper, a CoronaVac paper, where they found really low levels of immunity, I think after 6 months after vaccination, with a primary series. And then they saw a steady or a plateau. So umakyat yung immunogenicity and seropositivity after getting a third dose. And that paper actually shows us na baka for CoronaVac, a third dose should actually be part of a primary series, not as a booster. And that's also one of the reasons why early on in my lecture, in my talk, I differentiated between a booster versus a third dose, kasi it's important to differentiate. So for CoronaVac, it seems that there's data emerging that baka better kung 3 doses rather than a booster, no? Or you give a heterologous, so you do heterologous and give a completely different vaccine. But I haven't seen any real world data on inactivated vaccines.
So, there's another question. Are there any population or cohort already identified, aside from healthcare workers, which should actually be given priority in terms of giving booster doses?
I'm familiar with US data, so mix and match data in the US, where they looked at patients with comorbidities, the same risk factors for getting a severe COVID infection. No? So patients with diabetes, patients with cancer, etc. Similar to they're having risk factors for severe COVID, it's the issue of their immune system. No? So when they're given a primary series, did they form enough antibodies to protect themselves? No? So the question of sufficiency of the primary series. Yun yung question for